recording and then take it away.
All right, thank you very much. And thank you for the opportunity to speak with you guys today and be a part of this pediatric neuroradiology teaching series. My name is Alex Foust, and I am an assistant professor at Vanderbilt University. All right, so let's get rolling here. So first off, no disclosures. I will say that most of the cases that are for this talk are cases that I got from Boston Children's Hospital when I was a fellow there. And if you are interested in the subject, several of these examples will be coming out in the next issue of Neurographics. So a shameless plug there to check out our midface paper. It's coming out soon. All right, so the goals for today, we're going to talk a little bit about midface embryology and kind of just talk about some of the pertinent pearls when you're thinking about pathologies that happen in the midface. We'll talk then about a location-based approach for identifying different sorts of anomalies that you might see in the congenital midface. And finally, we'll discuss imaging features of a few craniofacial syndromes. So a few background pieces before we get rolling into the embryology. Imaging for the midface is generally best accomplished with a multimodal approach. When you're using CT, you want to consider having 2.5 to 3 millimeter slice thickness. It's great if you can be parallel to the hard palate. Occasionally, you may want to angle up 10 or 15 degrees, depending on what you're trying to visualize optimally. You don't generally need contrast, but you may consider giving contrast if you are looking for something in the anterior skull base where the cribriform plate has not fully ossified until about the age of 3. In that case, you can give the contrast to kind of better delineate the cartilage from pathology. For MRI, you want to have high resolution imaging. It's good to have at least one of your T1 series that doesn't have fat sat to really give you some nice imaging planes. And diffusion weighted imaging is also definitely a plus if you can have it available. Fetal imaging, you want to consider both curvilinear and linear probes to try to best optimize the anatomy. Transvaginal can be helpful if the fetus is head down. And for MRI, single shot fast spin echo and true FISP are going to be kind of your main workhorses. You can also consider cine images when you're looking for palatal defects, trying to see the positioning of the tongue relevant to the palate and things like that. All right, so briefly, just looking at the ossification of the skull base. This is from a nice paper by Hughes et al. In the AJNR, which just kind of looked at how long it takes for the pediatric skull base to ossify. And it's, again, something to keep in mind when you're looking for defects in the anterior skull base, that when you have a CT in a young patient, there's cartilage there that you won't necessarily see well early on. And then in most patients, 100% in this study had complete ossification of the anterior skull base by 3 years, 10 months. So that's a good hard stop point for when you should say, okay, I expect it to be ossified by this point. All right, so talking a little bit about the embryology, the midface basically has 3 centers that are going to produce the 5 pieces of facial prominence. So you'll have a single frontonasal prominence. You'll have paired maxillary or maxillary prominences, and you'll have paired mandibular prominences. And those will kind of come together over time to give you the fetal face. The frontal nasal process also gives rise to medial and lateral nasal swellings, which are going to be involved in development of the midface as well. And as you can see, you start out with a nasal placode. You'll develop into nasal pit, nasal sac, subsequently starting to resemble more of a human face as the maxillary shelves are going to come in and join the medial nasal processes and lateral nasal processes. And finally, when you have the complete descent of the midline mesial nasal swelling to form the more adult type face. Neural crest cells are important, and a lot of the midface comes from derivatives from the first pharyngeal arches, which is important because then pathologies that affect remnants from the first pharyngeal arch can be affected in some of the craniofacial syndromes that you'll see. All right, so talking about the affected regions, I have this kind of organized just based on location. And so we'll start in the nasal area. And so a little bit more on the embryology here. You start out with the nasal placode, as we saw in the former slide. In the 4th week of gestational life, it starts to invaginate backwards and it forms this little pit. Then that little pit will kind of extend down and it will join the stomadeum, which is going to be the fetal mouth eventually. And it's got like ectoderm coming back. And it'll rupture down into this stomadeum and it'll have this little sac that it forms. Then your little sac will extend backwards. So you have to kind of think of this in 3-dimensional space. It's almost like a little tunnel that extends backwards. And the bottom of it will pinch off to form this buccal nasal groove that will close off by the buccal nasal membrane. And then the very back of that groove, there will be a thinner part, which is going to thin out and come the oral nasal membrane. And the oral nasal membrane eventually will rupture and form the posterior choana about the 6th week of life. Now, when you get to the 6th week, the posterior choana isn't in its final resting spot per se, because the face continues to develop and the palate is going to come in a little bit later and move things around. But it should be open at that point, and eventually it will move a little bit more posteriorly to its final ending point. So talking about, some of the pathologies in this region, this is a pretty extreme example. This is a case of arrhynia. And in this situation, the nasal placode's never involuted at all. So if we think about if we were way back here where we only have our little placodes, really none of the precursors that are going to form the nasal structures are there. And as a result, you end up with complete absence of the nose. It can happen bilaterally and you can have a complete arrhynia. It can also have hemiarrhynia if only one of the placodes fails to involute. And as might be expected, depending on the size involved, the maxilla is also going to be implicated and the olfaction system, both of which are related to that early frontal process, which is going to give rise to that portion of the midface. All of these cases are going to need airway management at birth. So if you are concerned about this in fetal life, it's great if you can bring it up to the clinical team. Number 1, because they may have other congenital anomalies, but also number 2, because they may need an exit procedure or some sort of plan for airway management at delivery. All right, so then we're going to move into piriform aperture stenosis. So in this situation, we're talking about early fusion of the medial nasal processes. So as you remember, the medial nasal processes were kind of surrounding the nasal sacs. And they do come together and they should come together and fuse at the midline. But if it happens too soon, then it results in a narrowing of the cavity. As a result, you end up with this neonatal airway obstruction because you have a very small pathway for air to pass. And as neonates are obligate nasal breathers, this can present pretty early in life with difficulty with respiration, particularly during feeds. You might also get a clinical history of failure to pass a small catheter. And so the imaging features that you're looking for with piriform aperture stenosis, you're looking at the anterior aspect here where the opening to the nasal cavity is, or the aperture. And this cavity, the normal width should be greater than 11 millimeters. Now, in cases of piriform aperture stenosis, it's often much smaller than that, often below 7 millimeters, and below 6 millimeters. Some of the cases in the literature have shown needed more surgical intervention. But you're looking for narrowing between this opening here, which is our piriform aperture, less than 11 millimeters. And there's some associated things that are going to happen with that. If you think about the fact that the midface is kind of squished together and came together too early, and you think of that moving its way down, not only is the nasal cavity narrowed, but the maxilla is narrowed as well. And it has an unusual shape. And so you'll get this triangular shape of the maxilla, and occasionally you'll see a single solitary mega incisor. The face is said to predict the brain. So it's important if you do see these findings to then look up, because there is an association with holoprosencephaly spectrum pathologies in the brain. And so if you see piriform aperture stenosis and or a solitary mega incisor, triangular palate, recommend an MRI of the brain if they haven't had one, just to have a look and see if there's any more midline fusion anomalies intracranially. A high number of these patients do end up being syndromic, and so it's worth taking a look. All right, next we're going to talk about choanal atresia. So when we talked about the nasal anatomy, we talked about this groove that works its way backwards, which is our buccal nasal groove. We talked about it kind of closing off and then forming this thin bucconasal membrane, which should rupture open to form the posterior choana. So in choanal atresia, the problem that we run into is that this oronasal membrane posteriorly never really ruptures. And as a result, you don't open up the back of the nasal cavity appropriately. The fusion is, at least in the literature, has always been either osseous or membrano-osseous, an atresia plate. You can have choanal stenosis as well, where the pathway may be ruptured but incompletely. But in the case of atresia, it's always osseous or membrano-osseous. It can happen unilaterally or bilaterally. If it is a case of bilateral, it's a common cause for neonatal airway obstruction. If it's unilateral choanal atresia, it doesn't always come to clinical attention right away because they are still able to breathe out of the contralateral side. So it may come to light a little bit later in life with nasal stuffiness, or maybe they got a cold and then the good side got congested and they come to clinical attention because they're struggling to have breathing issues or difficulties with feeding, etc. But if you see unilateral or bilateral, you definitely want to look and see for potential syndromic findings. Choanal atresia can happen by itself, and definitely unilateral is more commonly isolated, but both unilateral and bilateral have a reasonably high occurrence with syndromic conditions such as charge syndrome, which is going to be coloboma, heart defects, choanal atresia, renal anomalies, genitourinary anomalies, and ear anomalies. And so let's look at an example of this. So here I have actually examples of both. So we have in the top here an example of unilateral choanal atresia, and in the bottom an example of bilateral choanal atresia. So some of the findings you're looking for here is narrowing of this posterior choana should be less than 0.34 centimeters in width. You will see inward bowing of the medial aspect of the nasal wall. You'll see thickening of the vomer. So if it's unilateral, you'll see thickening only on the side where there is actual atresia. If it's bilateral, the whole vomer will be thickened. And you should see this little osseous or membrano-osseous atresia plate that extends across the back of the defect. Often you'll also see pooling nasal secretions, and so that can be another helpful finding. And this is just a companion case to show you what this might look like in utero. So this is a patient who had charge syndrome, and you can see that there's actually bilateral choanal atresia, which we can see in the fetus. Also had a coloboma here on the left side and deficient semicircular canals, which are also additional findings that are seen in charge syndrome. Okay, so let's move to the nasolacrimal duct and that pathway. So the nasolacrimal duct is basically the duct. It's going to extend from the lacrimal pathway down to the opening in the nose. And you have this little valve here in fetal life, the Hasner's valve, that's always there, and generally it will perforate, but not uncommonly it doesn't perforate until neonatal period or after birth. I think the numbers are quite high, almost like 1 in 5 or something. Neonates have at least some residual Hasner's valve that causes some stenosis and some secretions related to the nasolacrimal duct. But most of those will kind of self-resolve on their own. So imaging really isn't a big part of nasolacrimal duct stenosis. But if you are looking for it, the normal duct is 5 millimeters proximally and 3 millimeters distally in neonates, and that number will increase as they get older. And what you'll really see is basically just sort of increased fluid distension of the nasolacrimal duct kind of behind the area of stenosis. So then sort of a related but a little bit different etiology is a dacrocystocele. So what happens here is you have this normal nasolacrimal duct pathway, which is forming when the lateral nasal process is joining the maxilla, the maxillary process embryologically. And so there will be this cord of tissue kind of where they come together that should involute. And if it doesn't completely cannulate, then you'll end up having an obstruction, which is where this dacrocystocele comes from. You can also get a more proximal obstruction, which can be functional or mechanical. And so you can end up getting actually dacrocystoceles both proximally and distally. And this is the second most common cause for neonatal nasal obstruction. And you can see them unilaterally or bilaterally. And so this is an example. And what we see here is a dilated nasolacrimal duct. You can see here it is near the level of the nasal cavity here by the medial canthus. And you can see sometimes in these cases associated displacement of the inferior turbinate and or nasal septum. And you know, a lot of times it doesn't really cause a whole lot of trouble. It can cause airway obstruction when the cystic component gets large and is blocking off the nasal cavity. Again, with neonates being obligate nasal breathers, that's where that will come to clinical attention. And the other time it comes to clinical attention is this example here, which is dacrocystadenitis, and that's when you get a superimposed infection. So you can see here there's pus kind of filling this distended nasolacrimal duct. You can actually see some here also working its way across the inferior orbit and some overlying cellulitis. And this is a companion case, which is just showing what a dacrocystocele would look like or does look like in fetal life. You can see this one's decently large. So you can see it's almost the same size as the globe here near the level of the medial canthus, a little bit smaller as it works down to its more distal component. But you could see why when a dacrocystocele gets to be this size, it could be potentially a cause for nasal obstruction in a neonate. All right, so that was our nasal region. Let's move forward then into the frontonasal area. And so this is going to be focused kind of in the midline, and we're going to talk about the region of the nasian and also the nasal bridge here. And so in fetal life, you have a couple of transient neuroforamina. So the first one is the funticulus frontalis, which is going to be this transient space that exists between the frontal bone and the nasal bones. And you also have a prenasal space, which is going to be positioned between the nasal bones and the nasal cartilage. So these are kind of potential fetal spaces that basically get obliterated by the time you get to the adult patient. During fetal life, you do have normally a transient dural diverticulum that will come through the foramen cecum here. And it will work its way through the prenasal space all the way up near the nasal tip. And then it will involute and regress. So this is an important structure because it serves as a pathway for potential pathologies that we'll talk about shortly. But you can also have persistent dural diverticula that will extend into other transient spaces. And so the funticulus frontalis, you can also actually get dural diverticula that extend into that space and will cause similar pathologies. So the first one of these entities is Encephalocele or Encephalocele. Now there's different kinds of encephaloceles, but for the purposes of the midface, we're going to be talking about the syncypital type. So this is going to be the type that involves the midface, the nose, the orbits, the forehead. And basically this group accounts for 15% of encephaloceles. And what we've got is herniated brain contents that are still connected to the brain, and that you still have subarachnoid space that has open communication with the defect. So that's an important point for differentiating this entity from one of our future pathologies. So you'll have this brain that extends down, often with arachnoid tissue. You can also just have meninges and arachnoid and no brain tissue, and then you would have a cephalocele that could go into the same space. And basically it's going to go into these transient spaces, these normally transient spaces in fetal life, but because there's brain there, the space doesn't get obliterated. So in the case of a frontonasal one, you're going to have a retained funticulus frontalis, and you'll have your encephalocele, which is going to pop out right in the region of the glabella. And in the case of a nasoethmoidal encephalocele, you'll have brain tissue that extends down between the nasal bone and the nasal cartilage. It's going to be kind of in the nasal root. You may or may not see this kind. Sometimes it'll present with a broad nasal bridge. Sometimes it will have a nasal mass. It just kind of depends on how large it is. There's a high association with intracranial anomalies. So these are going to definitely necessitate MRI for full characterization. And because there's this persistent connection with the arachnoid space, the clinical exam may show signs that the quote mass they're seeing changes in size when the infant is crying or straining Valsalva. Anything that's going to increase pressure intracranially will cause this to sort of bulge and change in size. The brain tissue that actually goes into the defect is often dysplastic, so the tissue itself is not generally salvageable. But as it is dysplastic, certainly could be a potential cause for seizures and things like that in some patients. So this is an example then of the frontonasal encephalocele. So, we see what we expect to see. So you have persistent opening here of the fonticulus frontalis. There's your frontal bone. There's your nasal bone in a fetus. This is the MR in the same patient showing the same thing. And you've got this herniated brain tissue that's extending between those bones into the region of the glabella. It's generally going to follow brain matter signal, but if there is gliosis in the herniated brain, you can see some increased T2 signal in MRI, which would correspond to underlying gliosis. This is a companion case then of another frontonasal encephalocele. This is a patient who is a neonate. You can see this one's quite large. You can see there's retained connection with the subarachnoid space. You've got CSF in there in case there was any question. This one actually has pieces of both frontal lobes, but a lot more from the left side and a little bit of intraventricular hemorrhage as well. All right, so then the next entity that we'll talk about in the same region is the nasal neuroglial heterotopia, sometimes called a nasoglioma. But a lot of people don't really like that name because that would imply that this is neoplastic, and really it's not. It's basically sequestered brain tissue that went along one of these pathways in utero and got pinched off from the rest of the brain. And so you've got these intracranial contents that go into these potential spaces, either the fonticulus frontalis or the prenasal space, and they got pinched off from the subarachnoid space. So this is an example of a frontonasal one, and this is an example of one in the prenasal space. But in both cases, you've got this remnant brain tissue. It's got kind of pinched off from the arachnoid intracranially, which is kind of the distinguishing feature. Clinically, they might look fairly similar to an encephalocele, but again, because you don't have that subarachnoid connection, really they shouldn't be pulsatile on exam. Extranasal ones will be the ones that come through the fonticulus frontalis, and intranasal ones will be ones that go into that prenasal space, and similarly might just present with a broad nasal root. For the intranasal ones, they are more common, and the right side, for whatever reason, happens a bit more often. And you can see a stalk that kind of connects back to the brain in 10 to 30% of cases. But importantly, as I mentioned, you don't have that subarachnoid connection around that stalk. It's kind of just like a fibrous stalk that remains. So here's an example. We have a soft tissue mass in the region of the glabella. This one's actually intranasal, but kind of in the region of the nasal root. It's going to kind of follow brain parenchyma, T1 and T2 weighted sequences. It can be a little bright on T2 if there's some gliosis in the component. These should show facilitated diffusivity. So if you're trying to tease this out from a dermoid or epidermoid, diffusion weighted sequence can be helpful. And generally they're non-enhancing, although there are cases where there may be a little bit of enhancement if some choroid was in the piece of brain that got sequestered. And as we said, no subarachnoid connection. All right, so the third entity for this area, again involving our same locations, is going to be the nasal dermoid or epidermoid cyst or sinus tract. And so what happens in this situation is that you have this dural diverticulum that comes down. It gets kind of up to the surface, and you end up having this neuroectoderm pull back some of these surface ectoderm cells with it. And so you have your regressing dural diverticulum that pulls some of these cells back where they aren't really meant to be. And because you have cells where they're not meant to be, they start to form pathology, either a dermoid or epidermoid, depending on which cell types get pulled back. 84% of these patients will have a sinus tract opening or a little dimple or tuft of hair at the skin surface. And intracranial connections are common at 57% of cases. That's important because this is going to serve, if there is an intracranial connection, as a pathway for infections to just climb on all their way up right into the brain. And so you'll have risk for meningitis. If they have a palpable lesion, either at the nasal bridge or at the nasal tip, these tend to be non-pulsatile because you, again, don't have that subarachnoid connection. They're not going to change with crying. And if they're not fully resected, or if we don't know that there's an intracranial component, you have the risk for both recurrence and meningitis. And important just to note, classically, we think of these as in the prenasal space, and that is definitely more common. But again, you can have a dural diverticulum that would travel along the fonticulus frontalis, and you could have one in the extending to the region of the glabella as well. Okay, so this is an example then of a patient with a dermoid. As with all dermoids and epidermoid cysts, restricted diffusivity is really going to be your friend. So it's nice to have, especially resolved diffusion can be nice to look at the area of interest and try to tease these out from adjacent nasal secretions and tissues. But this is a patient who had one that had some proteinaceous and fatty components in it. So you can see that the lesion was T1 bright. They actually have another separate little component that's extending more posteriorly along the surface of the brain here. And you see a little sinus tract as you go slightly to the side that goes right up to a little pit on the surface of the nose. And here's the tract extending back posteriorly towards that foramen cecum. And this is just a companion case. Unfortunately, this one did not get performed with diffusion, but fortunately, I suppose we can at least see that there is this intracranial component, cystic. These things tend to have a little thin rim of enhancement or no enhancement, and can have surrounding inflammatory change when they're super infected. But the take home point here is if you suspect a dermoid or dermal sinus and you see something at the tip or along the nasal root, just make sure you look back to where the foramen cecum is. We know this is the pathway that they come from, and we know this is the pathway they can travel along. And we don't want to miss this intracranial piece because then the patient can end up having recurrence or meningitis. All right, now we're going to shift down a little bit into the lower part of the midface and talk about the palate. And so cleft lip and cleft palate is kind of a large topic in and of itself. So we're just going to talk about a few of the basics for the purposes of our discussion today. So the primary palate is going to be this triangular shape. It's formed between the anterior aspect of the maxilla, between the two lateral incisors, and it forms back in a triangle to the level of the incisive foramen. So the four maxillary incisors are the only teeth that are in that primary palate. And the secondary palate is both the hard palate and the soft palate that are behind the incisive foramen. So the primary palate is going to be formed related to those medial nasal processes as they fuse at the midline and come down, whereas the secondary palate is formed from palatal shelves from the maxillary processes as they're coming in. So they actually are coming from different structures embryologically, and that's perhaps why we see differences where you might have clefting of just the primary palate or just the secondary palate or both. And so when you're talking about a cleft palate, cleft lip, we kind of want to distinguish what we're dealing with. So you can either have a cleft lip plus or minus a cleft palate, or you can just have isolated clefting of the secondary palate. You don't generally have an isolated cleft primary palate without lip, but I suppose it's possible. And then you want to talk about whether you have unilateral or bilateral clefting and whether you have complete or incomplete clefting. And so the nomenclature then is just a point that's discussed in the literature a lot. Sometimes things get lost in translation between the radiologist and the surgeons working on these cases. And so I think it's usually best to just be descriptive with these cases. And so you want to talk again about the unilaterality. Is it unilateral or bilateral? If it is bilateral, are the clefts symmetric or asymmetric? Does it involve the lip, the alveolus, and the palate? And if it does, are they complete or incomplete? And then the secondary palate, which again is going to be everything behind that incisive foramen, can be described using this Vaux classification. And so you'll see that a Vaux 1 is the mildest form of a secondary cleft palate, and it just involves basically clefting of the uvula. When you have a complete cleft of the secondary palate, you'll then go into the range of a Vaux 2, so it can go all the way up to that incisive foramen. And then Vaux 3, you actually have clefting of the primary palate and the secondary palate, but only on one side. And in the Vaux 4, you end up having clefting of both sides of the primary palate. When this happens, you actually get this premaxillary segment that kind of extends out into space. So in the fetal world, you might have this protruding premaxillary segment. And then the Kernahan Y, this is a diagram of it. And actually, like in fellowship, we had this on our sheets when we would read these fetal cases, and kind of you would mark off the components that you thought were involved. And this can be helpful. Some of the craniofacial surgeons will put something like this in their notes as well, just so everybody's on the same page for what segments are actually involved in the cleft when you're communicating. And so here you can see as the incisive foramen, you can see that 9, 10, and 11 are going to be used to define the hard palate and soft palate, and that 1 through 8 are going to define the components involving the primary palate and the lip up to the nasal veneer. All right, so then let's look at a few examples just to put this into practice. I do have an example of a normal palate here just so we could look at it in the fetal world. So what we'd like to see is a U-shaped palate. You'd like to see the tooth buds being relatively symmetrically distributed across the palate and just a nice homogeneous structure. In the coronal plane, you like to see the vomer come down, and the vomer should hit that hard palate all the way front to back. So if you lose that connection, which is an example here we'll talk about, that's usually means that you have a defect in the secondary palate. And then finally, in the sagittal plane, you can see the secondary palate illustrated nicely. This can be tricky, and sometimes if you do have Stenosis, it can help because you want to have it outlined by fluid in the fetus to really get a good look and outline both the nasopharynx and the oropharynx around that palate to distinguish it from the tongue. Sometimes you can infer it if the tongue is positioned very high and posteriorly, but you feel a lot more confident if you can have it outlined nicely with fluid. All right, so then this is an example of a patient with a Vo2 cleft. So again, that's going to be a complete cleft of the secondary palate. And they also have Robin sequence, which is something we'll talk about next. But what you can see here when we look at this is this palate doesn't have the right shape. It looks like a triangle. It doesn't have that nice rounded morphology. The vomer comes down and then you lose it. And you got this little fluid that lines the vomer. That shouldn't do that. Make sure that vomer goes all the way down and intersects the palate. And then when we look at this in the coronal plane, you can see the tongue is high, it's posteriorly displaced, and we don't see a second fluid-filled canal. We just see the one common canal between the oral cavity and the nasopharynx. This is another few examples of fetal clefts, just to show a few more of the entities. So this is the mildest form. This is a nice example. Actually, I think ultrasound maybe even is a little bit better, but you can see it on the MRI as well. A very small cleft in the lip with incomplete cleft lip, and the palate in this case was normal. So this is about the mildest end of the spectrum you're going to get. This is an example of a Vo3. So remembering that you have a defect of the entire secondary palate and one side of the primary palate. And this is an interesting sign that's been talked about in the literature. You'll hear it called like an L and anti-L. So you'll have the vomer come down. It still intersects the palate where it's supposed to, the secondary palate, on the side where you have the primary palate, I'm sorry, where you have the intact palate, but on the side where it's absent, you'll have just a fluid-filled space. And so that'll form either your L or your anti-L in this case. More posteriorly, you can see the whole thing is just outlined by fluid where the secondary palate is deficient. And this is showing you in the axial plane where that defect in the alveolar ridge is and the absent secondary palate. And then this is a Vo4, just showing you there's that premaxillary segment we talked about. It kind of can protrude out a little bit from the rest of the face because you have the clefting on both sides. And then again, this patient had complete deficiency of the secondary palate and probably some inferior vermian hypoplasia and ventriculomegaly as well. Okay, so Robin sequence then is going to be something that can happen in the setting of a cleft palate. And what the background that's going on here is that you have this triad. You have micrognathia, and that's thought to be the forerunner in this sequence. The jaw is too small, the mandible is too small. Because the mandible is too small, you get glossoptosis. And so the tongue is kind of pushed backwards and upwards, and you end up having airway obstruction as a result. With the tongue being up and back like this, it prevents the palatal shelves, which come in from both sides from the maxillary processes. They normally come in and then they will sort of zip up along the midline. And so the tongue is in the way and blocking it, and you end up having this U-shaped cleft in the secondary palate because the tongue blocked the palate from ever sort of zipping up together properly. And there's a lot of syndromic associations with Robin sequence. Sometimes you'll see this called Pierre Robin sequence as well. I've heard both. I always taught Robin, so that's kind of what I stick with. But some of the more common associations, 22q11, Stickler, Treacher Collins, but there are numerous. So I wouldn't, if you see Robin, I wouldn't necessarily suggest a particular syndrome, but you probably want to think about having genetics involved just because there is a high number of associated syndromic abnormalities. Okay, and then briefly, let's talk about facial clefts. This is a really complex topic and they're incredibly rare, so we're not gonna go too crazy, but there's a system called the Tessier system, which is numeric, and it's used to kind of define facial clefts, 0 to 14, using the orbit as your landmark. And so you'll see 0 is right at the midline, below the nose, 1, 2, 3, 4. You work your way out and then up and around into the forehead. The typical cleft, when you think of cleft lip and palate, is this Tessier 1. And then it's important to keep in mind that the soft tissues and the bones don't always coincide, and you can have combinations of the clefting. So if it involves the lower part of the face and the upper part of the face, you will list both numbers as the Tessier that you're dealing with. And so this is an example of that. This is a patient with a Tessier 311 facial cleft. So we can see that she has hypertelorism. You can see that this nasal root is quite wide. She actually has partial duplication of the nose. And she's got this cleft then that extends up on the left side from the nasal ala superiorly and heads towards the medial canthus. And then on our 3D and our bone windows, you can actually see that it goes past the medial canthus and extends up into the frontal bone on the left side. So this was just an example of that Tessier system in practice. I would say overall, this is one of these things that's probably better you look up if you happen across one of these very rare cases, but interesting nonetheless. Okay, so then lastly, let's talk about a couple of craniofacial syndromes, and then hopefully we will have some time for questions and get you on your way. So the first one I want to talk about is Treacher Collins. And this is an autosomal dominant mutation. There's a few different mutations that have been described in the setting of Treacher Collins. But basically you have first and sometimes second branchial apparatus structures that are involved and abnormal. And so you'll see that you have underdevelopment of the face and of the temporal bone structures, which come largely from the first branchial cleft. And then you can also have mandibular hypoplasia coming from the second. And so you'll see hypoplasia, and the malar evidences will be posteriorly slanted. And you might also see either small or completely, in this case, absent zygomatic arches. The face just looks kind of flattened and sunken with a small jaw. And in the temporal bone, you will also see findings that you expect with first brachial apparatus abnormalities. So you'll have external auditory canal stenosis or atresia. You'll have hypoplasia of the middle ear cavity. The ossicles are often absent or else very abnormal in appearance. And you may have oval window atresia, round window stenosis, things like that. And you may also see a cleft palate in these patients. Again, there is this high sort of syndromic association with the Robin pathway, and you can see why. Again, you have that small mandible and the tongue is pushed up. This patient actually ended up closing their palate, so they didn't have a secondary palatal defect, but you can certainly envision a lot of these cases where the palate won't have the opportunity to completely zip up. Okay. Then we have Apert syndrome. So this is one of our syndromic craniosynostoses caused by an autosomal dominant mutation in FGFR2. There are a lot of these synostoses that have different mutations in FGFR2, and they sort of have features in common and maybe some features that are different. So with Apert, you get this turi brachycephalic appearance of the calvarium. So you're going to have a very tall forehead, and you're going to have shortened anterior posterior diameter of the calvarium because you have bicoronal synostosis. And so when you close off your coronal sutures, the calvarium then loses its ability to grow appropriately in the anterior posterior direction. And so the areas where it can grow, it sort of overcompensates. And so you'll have splaying of the sagittal suture, and the head will try to grow more sideways instead of anterior posterior. And that's what kind of gives you your brachycephaly. You can still have sort of this more turicephalic appearance because you've still got growth along your lambdoid sutures and your squamosal sutures. They all tend to have this shape to the orbits, and the severity will vary a little bit, but they're kind of shallow, right? And maybe the angulation is a little bit more extreme than typical. The globes might seem to push out almost a little bit, which some will call exorbitism, and they may be wide set or hyperteloric. The midface tends to be small, so you'll see midface hypoplasia, and kind of going together with that, the nasal cavity will also be small, and you can have nasal cavity stenosis. You can have a shortened hard palate, and you can have a cleft plus or minus with that. And you might see it be high arching as well. I think this 3D really shows the sort of mid-face underdevelopment nicely compared to the mandible there. They can have bilateral symmetric syndactyly, and so can be hands, can be feet, and that's like a more peripheral finding, but if you're practicing a pediatric radiologist, something else to be on the lookout for. If you're the neuroradiologist, then just look for the X-ray reports and see if it's there. And they can have a variety of other findings. They can have inner ear anomalies, particularly semicircular canal defects. They can have jugular foraminal stenosis and ventriculomegaly. Those kind of can run together. There's a school of thought that argues that the jugular foraminal stenosis contributes to intracranial venous hypertension, and as a result, they can subsequently develop ventriculomegaly from the venous hypertension. Certainly the skull base can also contribute. You can see that there's a lot of basilar kyphosis here, and you may end up getting some altered dynamics at the craniocervical junction as well. And then they also occasionally will have cervical spine fusion anomalies. So take a look in your field of view to see if you see any fusion anomalies. All right, and then lastly, we've got Crouzon syndrome, another one of these Stenosis syndromes with a mutation in FGFR2. And you'll see that there are some similarities here, particularly when we take a look at the orbits. They tend to have bicoronal craniosynostosis, but a lot of the Crouzon's patients will have additional sites of synostosis. So you can see this example has coronal synostosis, but also has squamosal synostosis and some lambdoid synostosis and sagittal synostosis. And so the actual head shape is a little bit less funky looking because there's so many different synostoses, but obviously your brain doesn't have quite the room that it needs to grow if you've got all these synostoses. You'll see the orbits, you can have similar findings. The orbits will be sort of protruding and shallow. The globes will be protruding and the orbits themselves are shallow, giving you that exorbitism appearance, and the orbits may or may not be wide set. In this case, they had actually relatively normal relationship, but you can have hypertelorism as well. Again, you'll see the midface tends to be short, and you can also have palatal defects. They can have low set ears with narrowed ear canals. And also, just like our Apert kids, can have the jugular foraminal stenosis. They can have tonsillar ectopia and narrowing at the foramen magnum, again, related to that skull base angle being kind of abrupt. And similar to our Apert kids, you want to be on the lookout for hydrocephalus and cervical syrinx. And then lastly, they can have vertebral anomalies. This one just has a small little cleft in C1, kind of incidentally noted when you were reading the head CT. All right, so here's some references. And then I will take any questions. Again, check out our developmental anomalies mid-face paper in the next issue of Neurographics as a shameless ploy if you found this talk interesting.
Definitely not shameless. I think it will help out a lot of people. These are great cases. Yeah, thank you so much. So Manish Bajaj, one of our radiologists at CHOA, says one of the best talks on the topic I've seen. Great cases. So yeah, these are really great. And if anybody has any questions, feel free to put them in the chat or in the question area. Let's see, one of the questions here. Can dermoid cysts also show restricted diffusion? If then, how do you differentiate from epidermoid?
I never differentiate them. I think dermoids and epidermoids can both restrict if you have some dermal elements mixed in there. And I think it should be the pathologist's job to tell us, to be honest with you. If I'm reading the case, it'll just say dermoid/epidermoid cyst.
Yeah, sounds reasonable. Yeah. Any other questions from the audience? Okay.
Happy to pull up any slides if anyone wants to see them. I know the embryology is a little crazy sometimes.
So I have another question. Barring the fetal period, do you see a lot of roles for MR in the developmental cases with clefts?
I'm not sure I understood that. Can you say it again?
Oh, I guess so. So I guess you see any role for MRI in these cleft cases as opposed to CTs? I guess the use of
for
CT.
a facial,
I guess
or a palatal cleft,
or developmental clefts, or for any of these.
I mean, I think the it would depend on the severity of the cleft, but I think, I mean, the most important reason I would be doing an MR in a patient with a cleft is because there's a decent chance that they have other things going on intracranially, especially if there's a bilateral complete cleft, or if there is only an isolated secondary palatal cleft. Both of those instances have a higher association with syndromic entities and intracranial anomalies. With a facial cleft, like a more complex, like a Tessier cleft, you might consider it, just because the soft tissues can be more severe than the bony clefting and vice versa. If you want that more soft tissue resolution of the MR, in that case, maybe you would consider doing the facial MR. Hopefully that answers the question.
I think so, yeah. Okay, another question. Can you re-explain the Pierre-Robin or Robin sequence?
Yeah, definitely.
Yes, these are definitely complex.
All right, so actually, you know what might be helpful? And then I promise I will re-explain it, but let's go back to the first slide here. So what's happening is, for the primary palate, you've got these medial nasal swellings that are coming together and fusing, and they join these two maxillary processes that are coming together, and that's giving you your primary palate. Your secondary palate is only from these maxillary processes coming together, and they almost zip up behind here. It happens a little bit later, and they start out coming together sort of inframedially pointed, and then they're going to come to the midline and they'll lift up and fuse. All right, so let's keep that in mind, and then let's go back and look at this slide again. Maybe that made it more confusing, I don't know. All right, let's see here. Let's go back to Robin. All right, so what you have then is you have a small mandible. Because the mandible is small, the tongue gets pushed up and back. Because the tongue gets pushed up and back, or glossoptotic, then you're blocking those palatal shelves from lifting up and zipping together in the midline. And then you have a resultant defect in the secondary palate. And so you've got the micrognathia, which causes the glossoptosis, and together they result in airway obstruction, which is the third piece of Robin sequence. Technically, clefting is not part of the sequence, but because the two happen together, you generally do get a U-shaped cleft of the secondary palate. But if you really want to be textbook for the definition, you don't have to have a cleft, and you can have Robin and still have an intact palate.
Yes. Any other questions, or anything else to read, to other topics you'd like her to re-discuss? Yeah, because all this stuff, I feel like, yeah, the more you hear these complex topics, the more you remember.
Definitely. The more you see, the more you can remember, for sure. And I think it's kind of interesting just to see how the understanding the embryologic processes kind of helps you think about the pathologies maybe that happen in those areas.
It's definitely, yeah. I mean, it's why we go into pediatric neuroradiology, right? So we like the embryology and developmental stuff, and see how that kind of plays out in fetal and neonatal and adult life. Yeah.
Absolutely.
Any other questions, comments? Thank you. Yeah, if there's not any other questions, then yeah, we can end a little early. And thank you so much again for this outstanding talk. It was definitely, I feel like I have to hear this stuff over and over again just to remember it, even though I practice pediatric neuroradiology all the time. So thank you again, and have a great rest of the week. We'll be off next month, and there'll be another talk in August. I think Judy Getty will be talking about epilepsy imaging then. So yeah.
Sounds good.
Thank you so much again.
Thank you.